Okay, so we're going to be talking about anisocoria today, which means unequal pupils, and it's a form of acute visual disturbance. So let's get into it. If I can make this presentation work. I'll give you an overview to start with, and then we'll talk about some relevant anatomy. Then we'll get into history and exam, and then the actual causes of anisocoria, which for your purposes, there's really only 3. So this doesn't need to be a really complicated topic, although it can be tricky if you're not familiar with the content. So the overview is what? Well, this is your curriculum this year. It's actually looks like there's a lot on there, and I guess there is, but there used to be 45 conditions on the curriculum. I've got it down to 30 after thinking about it over the summer, and hopefully it's sort of intuitively organised into common conditions and serious conditions, and they're the ones that you need to know. There's anisocoria, that's where it fits in. It's potentially serious. Often it's not, but anisocoria can mean brain tumour, so it goes in the serious bucket. And I've put it next to ocular motor palsies because it can involve nerves. It does involve nerves. Nerves that supply the iris, which is why it's there. Here's another way of organising your curriculum. So in ophthalmology, people either present with red eyes or they present with visual disturbance, or both. And anisocoria is a cause of visual disturbance, not so much red eye. Okay. What are our objectives for today? Well, you need to know some relevant anatomy. You know, if you don't know the full pathway, you're not going to fail. But for your understanding, it's important to know some. You need to know what history to take and how to perform a pupil exam properly. You need to diagnose the most likely cause. And as I say, there's 3 main causes that we're focusing on. There's more, but there's 3 main ones. And then appropriate management. Anisocoria. An means not. Iso means the same. Coria in Latin actually means skin, but in this case, it applies to the eye, so it means pupils. So pupils that are not equal. Okay. So here's a patient with clearly unequal pupils. And if you look closely at her, you'll see that her left upper eyelid, so on your right-hand side, is lower than her right upper eyelid. So my first thought would be, does this person have ptosis and meiosis? Meiosis being a constricted pupil in the left eye, which is part of the triad of Horner syndrome, which we've already talked about. The reality is you don't actually know which is the abnormal pupil until you've examined them. So it could be that she's got a dilated right pupil and she just happens to have an upper lid on the left-hand side, which is a bit lower than the right. So yeah, it might be a Horner's, but you need to assess her. So a lot of people have a bit of asymmetry anyway, and that's physiological. But anisocoria is when it's at least ½ millimetre different, if not a full millimetre or more difference in pupil diameter. And what that means is it's either not dilating properly, which is a problem with sympathetic supply, as in Horner's, or it's not constricting properly, which is a problem with parasympathetic supply. Okay? It's quite common. A lot of it will be physiological, and then the rest you need to assess very closely. And as I said at the start, can be benign, but can also be life-threatening. So that's why it goes in the serious basket. This is the main takeaway slide from this lecture. Okay, so I'm going to put it right up the front of the lecture, and I'll go through it with you now. And this is the approach to assessing and diagnosing the cause of anisocoria. Okay, I'm going to go down the middle of the sort of flow chart first, because that's physiological anisocoria. So the key thing to determine with anisocoria is what's the abnormal pupil. The way you do that is to examine the pupils under dim lighting conditions and then brighter lighting conditions. Okay, so what are the pupils doing in the dark, and what are the pupils doing under bright light, right? And this should be fairly intuitive. Okay, if the abnormal pupil is the smaller one, it's going to remain smaller even under dark conditions, right? It's not going to dilate, whereas a normal pupil dilates. So if the small pupil is affected, it's worse under dim light conditions. The reverse is true if the big pupil is affected. If the big pupil's the abnormal one, it's going to be worse under bright light conditions because it's not constricting, right? If there's no difference between light and dark, that's physiological. You just happen to have pupils that aren't symmetric, okay? So that's our starting point. You examine them under dim conditions, you examine them under light conditions. Maybe there's up to 1 millimeter of difference in diameter, but it doesn't change based on the lighting. So that's when you think, okay, this is physiological. There's no other clinical signs, I'm happy. Let's now go to greater under bright light, right? So this is the big pupil because you turn the lights up and the anisocoria gets worse because the normal pupil constricts, bright light doesn't like it, constricts. The abnormal pupil dilates. So worse under bright light. What you want to do there, so this is sympathetic supply, right? And what you're worried about there, sorry, parasympathetic. Sympathetic is Horner's, that's the other one. Parasympathetic is supplied by the third nerve. So the first thing you want to ask yourself is this a third nerve palsy, right? Oculomotor nerve. Third nerve palsies cause problems with ocular motility, right? The eye doesn't move properly. And the classic sign is the eyes turn down and out. The eyes down and out, and you get a ptosis, right? So if you've got a big pupil, ptosis, the eye's not moving properly, turn down and out, very suspicious for a third nerve palsy. If you don't have those things, then you're thinking about another condition called 80s tonic pupil, which I'll talk about later. That's as much as you need to know for now. All that stuff about pilocarpine, I'll talk about a bit later. But in a nutshell, the asymmetry is worse under bright lighting. Therefore, we think it's the large pupil that's affected. You check the eye movements, you check the pupil height. It's either a third nerve palsy or it isn't. Okay? So that's abnormal large pupil, anisocoria. Abnormal small pupil is worse under dimly lit conditions. And this is going to be your Horner syndrome, or where you're worried about Horner syndrome. So under dimly lit conditions, the normal pupil dilates, the abnormal pupil doesn't dilate as much, the anisocoria looks worse. And then again, so you'll be looking for ptosis, and then I'll talk a bit about aproclonidine, which is an eye drop, which helps with diagnosing Horner's, basically. I'll talk about that later. But this is your basic approach. You're examining both pupils under dim lighting and bright lighting, and that will help you determine which is the abnormal pupil. Let's now go backwards a step and talk about anatomy, okay? So pupil constriction and dilation are served by two muscles. Constriction is served by the sphincter muscle, which is like a ring surrounding the pupil, and constriction is parasympathetic. Dilation is sympathetic, and the dilator muscle is like bicycle spokes, so it's radially oriented. That's sympathetic. The easiest way to think of this is when we're excited, you know, tiger jumps out of the bushes, so that's a sympathetic aroused state. Pupils dilate because you want maximal visual information, maximal light, run away, you know, so you don't get eaten. The opposite is true, so that's sympathetic, okay? Parasympathetic is when you're relaxed, right? So you're relaxed, you've just had lunch, you're sitting under a tree, drinking a cup of tea, pupil constricts. And there are drugs that mimic both of those actions. So amphetamine drugs give pupil dilation, whereas opioids give pupil constriction because they activate things adrenergically. Adrenergic tone either goes up or it goes down, therefore your pupils dilate or they constrict. So that's the way to remember, you know, how they're supplied. Pupil reflexes are autonomic, they're not voluntary. And it's a response to adrenergic tone, as I mentioned, but also light. So very bright light, you'll constrict. And we'll get into why. And as I said, sympathetic and parasympathetic to the two muscles. Bit more detail now. So let's talk about the sympathetic pathway specifically. Sympathetic ends up with pupil dilation. So on the top left of your image, you'll see iris dilator muscle and Mueller's muscle. Mueller's muscle is smooth muscle in the upper eyelid. There's a corresponding smooth muscle in the lower eyelid. So when you're sympathetically activated, not only does the pupil dilate, but the eyelids raise slightly as well, again to let more light in. That's sympathetic activation. So that's that sort of end product, if you like. But the sympathetic pathway starts in the hypothalamus, okay? And then you get a second order nerve going from the spinal cord that projects to something called the superior cervical ganglion. And from there you get the projection via the fifth cranial nerve to the dilator muscle. So it's actually a three-step chain. And as I said, it starts in the hypothalamus, from there projects to the spinal cord. C8 to T2, somewhere in there, the ciliospinal center of Budge, it's called. Not sure who Budge is. I should look him up. The reason that this is important is because clinically you can determine where the lesion is likely to be. Is it something in the hypothalamus? Is it stroke or demyelination or, infection? Is it something in the spinal cord? From the spinal cord, it then projects over the top of the lung and up the internal carotid artery. So the two conditions we worry about there are lung tumor, apical lung tumor, or the very important one is a carotid dissection. Carotid dissection as an acute presentation is life-threatening, okay? So if someone presents with pain in the neck, and if their sympathetic pathway is knocked out, then they're not going to dilate, they're going to have a constricted pupil. So that's your Horner's type presentation, right? So they've got miosis, ptosis, pain in the neck, you're worried about internal carotid dissection, okay? From the superior cervical ganglion, it basically then goes into the cavernous sinus in the brain, and then first on cranial nerve 6 and then on cranial nerve 5, and then it supplies the iris dilator muscle as well as the eyelids. So that's your sympathetic pathway. Your parasympathetic pathway is a 4-neuron pathway, and it's sort of the opposite in that it, instead of starting in the brain, it starts in the eye, okay? So parasympathetic leads to pupil constriction, yeah? This is what supplies the pupil light reflex. So when you look at light, your pupils constrict. That's a parasympathetic supply. Therefore, it starts within the retina, the retinal ganglion cells. They're the ones that detect light. They say, whoa, there's light coming in, okay? We'll start sending signals to activate the pupil reflex. So the signals go from the retina posteriorly. There's the optic chiasm, which you might remember from anatomy, where half the fibers cross over in the middle. So you've got one optic nerve, another optic nerve, half the fibers cross over, they go to the other side of the brain, and they end up in a nucleus called a pretectal nucleus, one on each side, right? You don't necessarily need to know the names of these nuclei. What you do need to know is that from those nuclei, they talk to another nucleus on the same side, but they also send fibers to the other side, right? And this explains why, if I shine a light in this eye, both pupils will constrict. Okay, that's why you get the consensual reflex, because information that's gone into this eye has been sent contralaterally to the other side of the spine or the brainstem, so that there's bilateral supply, despite the input being only from one side. Does that make sense? You guys happy with that? Decussation, we call that, right? So that's the Edinger-Westphal nucleus, where you've got one on each side, you get decussation. From there, it then basically travels back anteriorly. So now it's coming back towards the eye on cranial nerve 3. It goes to the ciliary ganglion, and from the ciliary ganglion, you supply the iris sphincter muscle, which I talked about before. The relevant parts of this clinically are if you get a stroke, an aneurysm, infarction, demyelination, etc., affecting the brainstem, that can affect pupil size and constriction specifically. That's why you get a blown pupil in someone who's got an intracranial bleed. And the other relevant bit I'll talk about later is atonic pupil, and that's to do with the ciliary ganglion, because it's a problem with the ganglion, so that the postganglionic nerves don't work. and parasympathetic pathways. Let's now get into history. So how do these people present? Well, sometimes they're asymptomatic and a friend notices or they notice it when they look in the mirror, but that you can get glare if you've got mydriasis or a dilated pupil. You can imagine if one pupil is very dilated, there's more light coming in, people are going to be light sensitive. And then impaired accommodation. Accommodation is the reflex. The accommodation reflex is when you go to look at something up close. And that also activates constriction and it helps us to read, right? When you're looking at something up close. So people might find that, oh, suddenly I can't focus at text as well as I used to. So that can be a symptom as well. Time course can be chronic or sudden. People can have had it for a long time, not noticed it, or it can present acutely. So, you know, access to old photos is good because that'll tell you if it's acute or chronic. There can be lots of associated symptoms. So they might have headache, ptosis we've talked about, double vision if it's a third nerve palsy, neck pain if it's carotid dissection, focal neurology if there's other nerves involved, pulsatile tinnitus if they've got raised intracranial pressure. So you're thinking about pathology in and around the head and neck, which can cause these types of symptoms. Here's an example. So, you know, we've talked about Horner syndrome. She's got a constricted pupil on her left, your right. And after putting in aproclonidine, which is an eye drop, which I'll talk about in a moment, you'll see that reverses, okay? So this is diagnostic for Horner syndrome. A normal eye, you put aproclonidine in, it doesn't dilate. So this is a diagnostic test for Horner's. Some relevant past ocular history is, have they had ocular inflammation or uveitis? Because if you get lots of inflammation in your eye, that can give you an abnormal pupil. Nothing to do with sympathetic or parasympathetic chains, right? But that pupil is more likely to be equal under dim and light conditions. There won't be a great deal of difference whether it's dim lighting or bright lighting. If they've had head and neck trauma or surgery, that can damage typically the sympathetic chain. So if they've had neck surgery and then you've got unequal pupils, then you've got to think about damage to the sympathetic chain. Therefore, they don't dilate, they have a constricted pupil. And then it can be pharmacological. So have they been taking atropine drops or sublingual atropine, somehow got a bit in their eye, or pilocarpine eye drops. So atropine dilates the pupil, pilocarpine constricts the pupil. So are you on any eye drops, you're going to ask. And yeah, sublingual atropine I talked about. Nasal decongestants can lead to pupil dilation. So have you started any new medication recently? Are you taking any nasal inhalers? Are you using any eye drops or sublingual drops? Okay. So that's the history. What about examination? Anytime in ophthalmology we say what examination you want to do, you say everything. And everything consists of these 5 elements. Okay? And the acronym is AFROC, A-F-R-O-C, right? So visual acuity, visual fields, pupil reflexes, which we'll focus on today. Ophthalmoscopy or fundoscopy, that's with the handheld ophthalmoscope, which you'll use this Friday. And then testing colour vision, which again we'll talk about on Friday. So I won't go through all of these now, but whenever you're in an OSCE situation, which you will be, what would you like to examine? I would like to examine the 5 components of a comprehensive eye exam. Thank you, tick. What aspect specifically would you like to examine? Okay. Often people forget that in an exam, so don't. So first of all, gross inspection. So do they have ptosis and strabismus? Strabismus means a turned in or out eye. So we talked about that, worried about third nerve palsy. Do they look like they've got proptosis? The whole eyelid is bulging forward. Well, then they might have a tumour in the eye socket, which can affect sympathetic or parasympathetic. Okay, so that's just standing back, gross inspection, always a good principle in medicine. Then your pupil exam. So dim lighting. Dim lighting means there's enough light that you can actually see the pupils. If it's too dark, you can't see the pupils. So it means typically curtains drawn, probably want to turn out the main lights, and then maybe you just got one lamp in the corner. Bright light means turn on the room lights and, you know, open the curtains, but not so much light that you get really full-on constriction, right? Distance fixation means give them a target on the wall behind you or wherever you're examining them from, so they're not looking at something up close. If you look at something up close, that's going to activate the accommodation reflex, which I talked about earlier. So if I'm looking here, both my pupils are going to constrict. So it's not going to be a good pupil exam because you've sort of got a false constriction going on. So if you're examining them, don't stand right in front of them because they're going to be looking at your shirt and their accommodation reflex is going to be activated. Stand to the side, give them a specific target, make sure the writing's light, and then you start your examination. You're going to test the direct reflex and the consensual reflex. We'll talk more about this on Friday. And what you're really looking at is size and symmetry, okay? So how much asymmetry is there? Is it up to 1 mil? Does it look like it's more than 1 mil? And is it different in dark lighting versus dim lighting? Finally, you do test the accommodation reflex. So take a pen, get them to look at the distance target, then say, look at my pen, and you're watching their pupils the whole time. And you want to see, is the accommodation reflex intact? Even if the light reflex is gone. So let's say you've got a big pupil, doesn't respond to light, it's clearly abnormal. In some cases, it'll still respond to accommodation. And I'll talk a bit more about that later, okay? So accommodation, in a sense, is separate to testing the light reflex. So a couple of examples. The top one, under bright lighting, the left pupil is bigger than the right? Patient's left, your right. Under dim lighting, that stays the case, right? But actually, if you look closely, the right pupil is actually the abnormal one because their left pupil has dilated under dim lighting. Do you see that? On the bottom image, under dim lighting, their left pupil has dilated, whereas the right pupil hasn't really moved. Do you agree? So that's how you determine normal versus abnormal. Look, the last thing you want to do with pupil exam is also, if you've got a slit lamp, if you're in an emergency department, look at them on the slit lamp. Because if the abnormal pupil is caused by uveitis or previous trauma or previous eye surgery, often you'll see something abnormal on the slit lamp and you won't be able to see it without the slit lamp. So that is part of the examination. So here you're thinking about structural defects. Look at these pupils. They're not normal pupils that are worse or better under dark or light. They're clearly structurally abnormal. So you're not going to see this often in your career, maybe never, unless you do ophthalmology. But in ED, you might see one occasionally where people come in with facial trauma, motor vehicle accidents, assaults, that sort of thing. Cells in the anterior chamber means inflammation in the anterior chamber. We'll go through this on Friday, and it's also in the clinical skills videos online. Again, posterior synechiae, don't worry about now, but these are signs of ocular inflammation. That pupil that you see there, the one on the bottom, is stuck to the lens behind it in various places. That's what posterior synechiae is. The pupil normally floats in front of the lens so that it dilates and constricts freely, but if it becomes very inflamed, it becomes sticky and actually sticks to the lens. So it's not going to dilate freely. And when it's got that sort of shape, you're worried about previous ocular inflammation, or uveitis is what we call that. If you're really keen with 80s pupil, which I'll talk about in a minute, you can examine on the slit lamp. In 80s pupil, the pupil doesn't constrict. It's one of the 3 causes that I mentioned, and it's a big pupil that doesn't constrict. But on a slit lamp, you'll see parts of the pupil trying to constrict. You'll see one sector that wants to constrict and the rest of it doesn't move at all. It's actually kind of amazing to watch on the slit lamp. And so that helps clinch the diagnosis of 80s, which is usually a benign idiopathic condition, and you can reassure the person, you know, this is safe. That image is meant to show that sectoral constriction. I'm not sure how well it shows it. It's better demonstrated on a video. Heterochromia means different coloured irises. So congenital Horner syndrome that you can be born with is a cause of one pupil being colored differently to another. It's one of the causes of different pupil coloration. These are all things that you can see on the slit lamp. Finally, because you're worried about cranial nerve, sympathetic, parasympathetic, third nerve, fifth nerve, so on, then you need to do a full cranial nerve exam as part of your, we're not going to make you do that in an OSCE, but in ED you're going to need to do that, on the ward you're going to need to do that, and you need to mention it in the OSCE, because there might be other nerves involved. It's not always a mononeuropathy. Okay, so this is just sort of recapping now. So anisocoria greater in the dark means the smaller pupil is the abnormal one, and here you're thinking about a Horner syndrome with the differentials being uveitis, pupil stuck down, can't constrict, sticky inflamed pupil, can't constrict, or mechanical, pupil's been damaged, can't dilate. Aproclonidine is a drop that we use to treat high intraocular pressure, okay? And it's an adrenergic drop. It's what we call an alpha agonist. So it's meant to stimulate sympathetic receptors. It does stimulate sympathetic receptors. Now, under normal conditions, that doesn't really affect the pupil, right? But in Horner syndrome, you get this parasympathetic, so you get this paradoxical effect where aproclonidine leads to pupil dilation because of something called denervation sensitivity. Denervation sensitivity means there's a problem with the synapse, okay? Synapse is broken, it's not working, right? Therefore, there's an upregulation of what are called alpha-1 receptors, which normally aren't activated by aproclonidine. This is a fair bit of detail now. You don't necessarily need to know this, but I think it's interesting, so I'm just going to tell you. Alpha-1, alpha-2 receptors. Aproclonidine normally works on alpha-2, but when the ganglion's broken, alpha-2 is not working, alpha-1 gets upregulated. The effect of aproclonidine on alpha-1 is pupil dilation. So you get this paradoxical pupil dilation with aproclonidine. The simple way to explain that is, you've got a small pupil, normally you put aproclonidine in, nothing happens. In a Horner's pupil, that pupil will dilate. Okay, so that's a take-home message. It's a simple diagnostic test, and you can get aproclonidine in the hospital. So there's an example there. Okay, so myotic pupil on the right, and under dim light, it remains that way. Yes?
For that effect to happen, does the Horner's meter have lasted for a certain amount of time?
Good question, and the answer will be yes, because denervation sensitivity isn't going to develop in hours. It's not going to develop in days. It's going to develop in weeks to months. And in an acute onset Horner's, if it truly is acute onset, you're not necessarily going to see that. And in that situation, it's going to be history exam and potentially photos that are going to tell you this is definitely new and not a long-standing problem. They've just happened to have seen it now. Yeah. More often than not, you're going to image those people. If they're presenting to ED with a suspected new Horner's, then more often than not, you're going to do neuroimaging head and neck to exclude internal carotid problem, chest X-ray, top of the lung, as I talked about earlier. Anisocoria greater in the dark. Okay, so this is the big pupil, that's abnormal. Third cranial nerve palsy we've talked about. The test here is pilocarpine, which is a pupil constrictor. Normally we use pilocarpine 1%, but here if you put in pilocarpine 0.1%, which doesn't normally do anything, in an 80s pupil you get constriction, again from hypersensitivity, okay? So for Horner syndrome, it's aproclonidine. For 80s tonic, when you've ruled out third nerve palsy, then it's diluted pilocarpine, okay? In reality, are you going to do this in an ED? Probably not, to be honest. The ophthalmology registrar might do it, but do it with them. Watch them do it and then look for the pupil responses, because you're not going to see it that often. It's a good clinical sign to see. And here's just an example of an 80s pupil that clearly persists under very bright light on the bottom image. Lid position's normal, the eye's not turned in or out. doesn't look like it's a third nerve palsy. So now you understand why aproclonidine is on this chart and why pilocarpine is on this chart, okay? If you don't get constriction to aproclonidine 0.1%, right, you're thinking, oh, I don't think there's any signs of a third nerve palsy. We'll put in this dilute pilo, doesn't do anything, there's no constriction. If it constricts 80s, if it doesn't constrict, you've got to revisit the possibility of a third nerve palsy. So you examine them again, and then you put in normal pilocarpine, and if it still doesn't constrict, you've then got to think, are you sure you didn't have a dilating drop put in the eye? Because if you put in a dilating drop like atropine, you can put in pilo and it doesn't really do anything. So you've got to revisit those bits of the history. Let's now talk about the actual causes, okay? There's 3 of them: third nerve palsy, Horner syndrome, 80s pupil, 80s tonic pupil, and then others. I'll quickly check off others first, because in a sense that's the easiest. Physiological we've talked about, up to 1 in 5 people, generally under 1 millimetre, equal in light and dark. We talked about that. Can be intermittent, it can be self-resolving, okay? So then we've got mechanical causes, okay? So that image, I wish I hadn't chosen this example because it looks like his right eye is turned out. It looks like he's got a strabismus. But what it's meant to show you is under light and dark, there's no difference in the relative anisocoria. Okay, relatively, his right pupil on the top looks constricted, and on the bottom, it's still the right pupil that looks more constricted. So, and relatively, it's equal. There's not a big change. Whereas if you've got a true cause of anisocoria, there should be a relative change under dark or light. So you've got physiological, then you've got mechanical and structural. We talked about that. It can be congenital or iatrogenic. Couple of images there. The pharmacological we talked about. They're the others after you've ruled out the nasty stuff. Okay. These slides will all be put on LMS, so you'll be able to go through this presentation and you'll have the video as well. So don't worry if you don't get it all the first time round. Ocular motor nerve palsy is covered in detail in one of our other lectures online. So I'm not going to go through it in detail now. It's a third nerve palsy. Third nerve supplies all eye movements except for abduction, turning it outwards, okay, and intorsion, which is what the fourth cranial nerve does. So what happens is, if you've got a third nerve palsy, because you've lost this tension from the eye being turned out, it turns in. Okay, so you've got an inturned eye, and because you've lost the fourth nerve intorts and it also elevates. So you get a depressed, right? So down and out is what the third nerve gives you. Third nerve palsy gives you, okay? The other point to know here is that with a third nerve palsy, pupil involvement makes you worried, because a third nerve palsy doesn't always have pupil involvement. You can have a third nerve palsy with a normal pupil. The reason a third nerve with pupil involvement, so with a dilated pupil, makes you worry is that the posterior communicating artery, so this image here, cartoon here, sits right above the third cranial nerve, and the parasympathetic fibers, which supply the pupil, are on the outside of that nerve. So if you've got an aneurysm pushing down onto the nerve, the parasympathetic fibers are going to be one of the first things to be affected. Therefore, the pupil becomes involved. If you've got a third nerve palsy from another cause, like an ischemic cause, the pupil's not necessarily effective. So pupil involving third nerve palsy is a problem. They need prompt imaging because you're worried about a PCOM, posterior communicating artery aneurysm. The rest of it I'm not going to go through, it's all there. And as I say, the other lecture's there, but in a nutshell, worry about pupil involving third nerve palsy. They need neuroimaging. Horner syndrome, we've talked about a few times now. So you remember it's a 3-order neuronal pathway. So the insult can either be central in the hypothalamus, stroke, tumor, demyelination. It can be preganglionic. Okay, so typically this is over the apex of the lung, or it can be postganglionic, where we worried about carotid artery aneurysm or dissection. Okay. Presentation, ptosis meiosis, we talked about that, plus or minus some other less common symptoms. Don't forget your differentials. Could be a third, could be a ptosis that's been there for a while. They just have become more conscious of it recently. Involutional just means age-related over time. Degenerate. A lot of people will get slight drooping of the lids as they go older anyway. And often it's not totally symmetric, right? And the management is what? Well, if it's an acute painful Horner's, they need prompt neuroimaging, okay? Because you're worried about carotid artery problem. Use apiclonidine, or get the registrar to use apiclonidine to help confirm the diagnosis, and the rest of it's based on etiology. So if they don't have a nasty cause, no lung tumour, carotid artery is okay, they might eventually just need ptosis surgery. So lift the lid up again, all right? But you need to exclude the dangerous, two main dangerous things: lung tumour, carotid artery dissection. And the prognosis depends on what it is, what the cause is. Okay. 80s pupil. So if you look, so earlier on I talked about accommodation reflex versus light reflex, right? This lady, her left eye, your right, on the top image, clearly isn't responding to light. That's a pen torch that's being shone into her eye, and it's clearly more dilated than her right pupil. On the bottom, they're giving her a near target, right? So both eyes are looking at that object, whatever that is, and both pupils have relatively constricted. So whilst it's still more dilated, it's less obvious than it is in the top image. So this is called dissociation between the light reflex and the accommodation reflex. And it's a diagnostic feature of 80s tonic pupil. Dissociation between light reflex and accommodation reflex, we call that light near dissociation. Light near dissociation. So that one's intact and one's stuffed. Okay? 80s tonic, most of the time, 80s tonic is not that uncommon. You probably see it as a GP, if that's what you do. Most of the time it's idiopathic, often post-viral, and more common in women than it is in men. I saw someone this week with an 80s pupil a couple of days ago. The etiology is a problem with the ciliary ganglion, okay? So parasympathetic denervation of some cause, right? So you get a dilated pupil, worse in the light, most commonly idiopathic, otherwise post-viral. There are other causes. Usually it's unilateral, tends to be younger women, and light near dissociation is a feature that you need to look for. The differential, you've got a big pupil, you've got to think about third nerve palsy. And that's where your pilocarpine test comes in. The management here depends on the cause, as usual, and often there's not going to be an identifiable cause. If the mydriasis or dilation is a problem, it might cause ongoing glare for the person, then you might prescribe them dilute pilocarpine to use for the short term at least. And then you can put a frosting on a spectacle glass or you know, a clear lens to help with glare. Okay, so that's the management of idiopathic 80s tonic pupil. Generally benign, but make sure it's not a third. Look, I think we've reached the end. I've put this up 3 times now, so this is obviously the most important slide, and hopefully, you know, once you've had a chance to review this material, I know that it's a lot, but once you've had a chance to review it, hopefully it makes sense. You're trying to work your way down to, is this physiological? Is it big pupil or small pupil that's abnormal? And then is it Horner's? Is it a third nerve palsy, or is it 80s? That's your job. And then who needs urgent neuroimaging and who doesn't? That's really what it boils down to, okay? Hopefully we've checked off all of those things. Thanks for listening.